Hello everyone, I'm back again. In this section, we will discuss about the histology and clinical anatomy of the kidney. So, do you know the difference in kidney stone and gallstones? Well, these stones will be differentiated later in this section. So first we will discuss the histology of cortex. Outer part is the cortex, glomeruli with proximal convoluted tubules, and distal convoluted tubules are there in cortex. Collecting ducts are also seen in cortex. Cortex also consists of capillaries. Now, let's discuss the histology of medulla. It has sections of collecting ducts, lots of sections of loop of Henle, and numerous capillaries. Now, let's discuss the clinical anatomy of the kidney. In surgical exposures of the kidney, when sometimes the 12th rib is resected for easier delivery of the kidney, danger of opening the pleural cavity must be borne in mind. The lower border of the pleura lies in between the 12th rib and the diaphragm. The order of structures, from anterior to posterior side, being diaphragm, pleura, and rib. When the 12th rib is absent or is too short to be felt, the 11th rib may be mistaken for the 12th, and the chances of opening the pleural cavity are greatly increased. Lithotripsy has replaced conventional method to some degree. Moving forward, the angle between the lower border of the 12th rib and the outer border of the erector spina is known as the renal angle. It overlies the lower part of the kidney. Tenderness in the kidney is elicited by applying pressure over this angle with the thumb. The kidneys are likely to be injured due to penetrating injuries to lower thoracic cage. These may also be injured by kicks in the renal angle, which is the angle between the vertebral column and 12th rib. Moving forward, blood from a ruptured kidney, or pus, in a perinephric abscess first distends the renal fascia, then forces its way within the renal fascia downwards into the pelvis. It cannot cross to opposite side because of the fascial septum and midline attachment of the renal fascia. Moving forward, kidney is palpated bimanually, with one hand placed in front and the other hand behind the flank. When enlarged, the lower pole of kidney becomes palpable on deep inspiration. Do you know that a floating kidney can move up and down within the renal fascia, but not from side to side? In such condition, the posterior layer of renal fascia can be sutured with diaphragm, and kidney can be fixed in position. The common diseases of kidney are nephritis, pyelonephritis, tuberculosis of kidney, renal stones, and tumors. Common manifestations of a kidney disease are renal oedema and hypertension. Raised blood urea indicates suppressed kidney function and renal failure. Kidney transplantation can be done in selected cases, such that donors left kidney transplanted as recipient's right kidney. One common congenital condition of kidney is polycystic kidney, which leads to hypertension. Moving forward, in cases of chronic renal failure, dialysis needs to be done. It can be done as peritoneal dialysis or hemodialysis. Discussion of artificial kidney without its mechanism is incomplete. So let's discuss the mechanism involved in artificial kidney. Term dialysis refers to diffusion of solutes from an area of higher concentration to the area of lower concentration through a semi-permeable membrane. This forms the principle of artificial kidney. Patient's arterial blood is passed continuously or intermittently through the artificial kidney, and then back to the body through the vein. Heparin is used as an anticoagulant while passing the blood through the machine. Inside the artificial kidney, the blood passes through a dialyzer, called hemofilter, which contains small channels interposed between two cellophane membranes. The cellophane membranes are porous in nature. The outer surface of these membranes is bathed in the dialyzing fluid, called dialysate. The used dialysate in the artificial kidney is constantly replaced by fresh dialysate. Urea, creatinine, phosphate, and other unwanted substances from the blood pass into the dialysate by concentration gradient. The essential substances required by the body diffuse from dialysate into blood. Almost all the substances, except plasma proteins, are exchanged between the blood and dialysate through the cellophane membranes. In addition to the dialyzer, the dialysis machine has several blood pumps with pressure monitors, which enable easy flow of blood from the patient to the machine and back to the patient. It also has pumps for flow of fresh dialysate and for drainage of used dialysate. So this is inlet for the entrance of blood, and this is outlet for return of blood to the body. Total amount of blood in the dialysis machine at a time is about 500 milliliters. The rate of blood flow through the dialysis machine is about 200 to 300 milliliters per minute, and the rate of dialysate flow is about 500 milliliters per minute. Do you know that? What is the frequency and duration of dialysis? Well, the frequency and duration of dialysis depends upon the severity of renal dysfunction. Dialysis is done usually thrice a week in severe uremia. Each time, the artificial kidney is used for about 6 hours. Now, let's discuss the dialysate in detail. The concentration of various substances in the dialysate is adjusted in accordance with the needs of the patient's body. The fluid does not contain urea, urate, sulfate, phosphate, or creatinine, so that these substances move from the blood to the dialysate. The fluid has low concentration of sodium, potassium, and chloride ions than in the uremic blood. But the concentration of glucose, bicarbonate, and calcium ions is more in the dialysate than in the uremic blood, moving towards uremia. Blood level of urea, nitrogen, and creatinine increases during uremia. Toxic substances such as organic acids and phenols also accumulate in blood. Artificial kidney can excrete more than double the amount of urea that could be excreted by both the normal kidneys. About 200 to 250 milliliters of plasma could be cleared off urea per minute by the artificial kidney. But the urea clearance by normal kidney is only about 70 milliliters per minute. There are complications associated with dialysis. Complications of dialysis depend upon the patient's condition, age, existence of diseases other than renal failure, and many other factors. Common complications of dialysis in individuals having only renal dysfunction are sleep disorders, anxiety, and depression. Now, let's discuss the peritoneal dialysis. Peritoneal dialysis is the technique in which peritoneal membrane is used as a semi-permeable membrane. It is also used to treat the patients suffering from renal failure. A catheter is inserted into the peritoneal cavity through anterior abdominal wall and sutured. The dialysate is passed through this catheter under gravity. The required electrolytes from dialysate pass through vascular peritoneum into blood vessels of abdominal cavity. Urea, creatinine, phosphate, and other unwanted substances diffuse from blood vessels into dialysate. Later, dialysate is drained from peritoneal cavity by gravity. Peritoneal dialysis is a simple, convenient, and less expensive technique compared to hemodialysis. Patients themselves can change the fluid on an outpatient basis. However, it has few drawbacks. It is less efficient in removing some of the toxic substances, and it may lead to complications by infections. Now, moving forward, kidney is likely to have stones, called as staghorn stones, as urine gets concentrated here. Do you know the difference in kidney stone and gallstones? Well, kidney stone lies on the body of vertebra. Gallstones lie anterior to body of vertebra. This was all about this section. In our next section, we will talk about the ureter in detail.
Explore our extensive library of over 1,800 video lectures to learn about a wide range of topics. Only on sqadia.com.